This meeting will be recorded and shared. While our presenters are speaking, we will have the lines muted to reduce unnecessary noise, but we will unmute at the end of the presentation. If you have questions that are burning in your mind, hopefully, you are welcome to put them in the chat box, and we will also answer those. So we encourage you to participate. We're going to have lots of times for questions. We're excited to share with you this research inspired by the Choosing Wisely 5 questions and a new toolkit for cost conversations. Now I'll turn it over to our physician consultant, Dr. Lisa Letourneau, to introduce the speakers.
Great, thanks so much, Kelly, and thanks everybody for joining us today. We're excited, as Kelly mentioned, to hear more about these upcoming tools to help engage with consumers about these discussions about high-value care. And to do that, I'm pleased to introduce Susan Perez and Beccah Rothschild. They're going to be going sequentially, but I'm going to introduce both together here. So we're very pleased to welcome Susan Perez. Susan's research focuses on understanding individual decision-making processes to help develop better healthcare policies, information, and resources to promote exactly these kinds of high-value decisions. Before her appointment as an assistant professor at California State University in Sacramento, Dr. Perez completed a postdoctoral fellowship in quality, safety, and comparative effectiveness research and has earned a doctorate in nursing sciences and healthcare leadership at the University of California, Davis. Beccah Rothschild is the principal of Health Engagement Strategies, a consulting firm focusing on patient engagement, health education, health literacy, and healthcare culture change. Before beginning that work, she was a senior outreach leader for Choosing Wisely, so she is well known to us. She worked on the Choosing Wisely campaign at Consumer Reports. She's worked for over 20 years in the fields of patient engagement, health literacy, and health communication in various capacities, including direct service, project management, research, policy, and interventions. She holds her master's degree in public administration and nonprofit management, and we are very grateful to have them both with us here today. So, Susan, I will turn it to you.
Thank you so much for that introduction. We would like to begin with for today's presentation, our objectives. So participants in today's webinar will learn the results of a multi-health system survey on cost conversations, understand potential opportunities for integrating cost conversations into care, and become familiar with the toolkit developed in response to the survey responses. We would like to start with thanking and acknowledging those who provided professional expertise as physicians, pharmacists, and medical billers, as well as research assistants in support and development of the survey, revising and providing input on the toolkit and analyzing our findings. We'd also like to thank and acknowledge the ABIM Foundation for in-kind support in the development and dissemination of the survey and toolkit. This project was supported by the Robert Wood Johnson Foundation mini-grant administered by America's Essential Hospitals and Essential Hospitals Institute. So for today's presentation, we'll begin with outlining the purpose of this project, our approach and methods for conducting this study, our findings and potential solutions, and lastly, recommended actions based on our findings. So there's a growing need for patients and providers to engage in conversations about the cost of care. And this is in light of rising patient out-of-pocket costs and waste of healthcare dollars, upwards to 30% in the United States. However, patients and providers are reluctant to engage in these conversations at the point of care, resulting in missed opportunities. So we embarked on this project to develop this toolkit in order to assist health systems in supporting healthcare personnel in recognizing opportunities for cost conversations, responding to cost questions, and redirecting and referring cost questions to the appropriate health system personnel. The result of this work is this toolkit. So in addition to health systems and the ways mentioned above, previously, this toolkit also highlights deficits among health system staff about how to have cost of care conversations and the ways those deficits impede staff's work and staff suggestions of proposed and actionable solutions. And advocates for health and how health systems we can become advocates to invest in in a culture of cost consciousness. We recognize that culture change and cost conversations are hard work. So for that reason, this toolkit also highlights barriers to implementing cost of care conversations, which includes the type of staff reluctant to engage in these conversations, why they're reluctant to engage, and what can be done either to motivate them to engage in these conversations or effectively redirect patients to the appropriate health system personnel. So for this study, we developed a survey instrument to measure health system personnel's experiences and perceptions with cost conversations. The survey instrument was developed based on a review of literature on existing survey tools, inquiring about cost conversations between patients and healthcare staff, and using topics that emerged from qualitative interviews with patients and physicians. We also used existing cost conversation survey instruments and expert feedback from national leaders. And even then, before fielding the survey, it went through 2 rounds of external review. So the survey was launched in February 2019 to a convenient sample of health systems that had completed the Choosing Wisely implementation prior to the launch of the survey. A request was made to one leader of the health system to disseminate the survey widely within their health system to physicians, nurse practitioners, physicians assistants, RNs, NAs, LVNs, MAs, pharmacists, pharmacy techs, psychologists, counselors, case managers, financial personnel, and administrative assistants, just about anybody who makes contact with patients. During the 2-week time frame in which the survey was open, the research team prompted health system leaders with 2 reminders to recirculate the survey within their system. Of the 35 health systems invited to participate, 14 did so. So this netted a total of 523 respondents, broken down as shown on the table here. The major findings of this project are: patients are asking about costs, specifically about out-of-pocket costs. Pharmacists, physicians, health insurance companies, and health systems are best positioned to talk with patients about treatment and medication costs, ways to lower these costs, and potential alternatives. Cost conversations should be normalized and not dependent on patients initiating these conversations. Staff demographics may play a role in who patients talk about cost of care. And health system staff members have not been trained to discuss costs with patients, but many would like to be trained. So in this next section of our presentation, I will highlight the findings of our study, and Beccah will introduce opportunities for change. So we learned that patients are asking about the cost of care. According to the survey respondents, the main questions asked by patients are, what will this cost me? So 45% of respondents reported that patients were asking them this question. This included a range of variations of types of this questions shared by survey respondents about out-of-pocket costs, which costs include co-pays, where they can expect co-pays such as for appointments and medications, for deductibles, supplements, or minor non-durable equipment and more. About 20% of respondents reported patients asking about alternatives, cost and treatment-wise. Patients are asking our respondents about foregoing and or delaying care, financial assistance programs, coupons, and opportunities to be treated elsewhere. 7% of respondents reported that patients are asking about indirect costs. Patients want to know how long they will be away from their job, family, or how daily living and activities may be impacted, and what side effects they might even anticipate. Lastly, 7% of respondents noted that patients are asking questions about understanding specific charges on bills, why they got a bill they weren't expecting, and why a test or treatment may cost more than expected. So, for example, the same medication may have cost them less previously. So one respondent noted, patients are asking me, is there anything cheaper? why do I need this now? Can I put this off until I can afford it?
Hi, this is Beccah joining, and I don't know if anyone else is in California, but I think we just had a very minor earthquake like 5 seconds ago. So anyways, thank you, Susan, for that.
Are you okay?
So
is everything okay?
Everything is fine. I just felt my house shake for a moment there while Susan was giving that last slide. So patients, as Susan said, are asking about costs. And as a result of them asking about costs, our survey respondents made suggestions of ideas or opportunities that their health systems and other health systems could consider in order to create change and better help their patients and their health systems. So please note that on this slide and on upcoming slides, I'll share various opportunities that we're offering throughout our toolkit. And at the end of our presentation, I'll let you know about existing resources that we've put together in our toolkit to help you maximize on these opportunities and not to have to reinvent the wheel. So with opportunity number 1, as the burden of out-of-pocket costs continues to escalate, patients will likely have a growing number of questions. Health systems should take this opportunity to develop resources and tools so that patients can better anticipate and understand their costs and simultaneously create systems and workflows to be better prepared to answer cost of care questions, likely leading to improved patient outcomes and trust between patients and providers. And opportunity number 2, as you see here, is to create CME trainings on what alternatives are clinically high quality and evidence-based. Because as you know, there's often more than one way to deliver high quality care.
So we also learned that pharmacists, physicians, health insurance companies, and health systems are best positioned to talk with patients about costs. And we learned this from the survey findings. So pharmacists felt that they were best positioned to provide patients with information about cost of medications. And similarly, 34% of those non-pharmacist respondents also felt that pharmacists were best positioned to provide this information. Pharmacists felt that within their health systems, they were best positioned to suggest cheaper alternative medications to patients. Similarly, other health system staff also felt that pharmacists were best positioned to provide this information. Physicians felt within their health systems, they were also well positioned to suggest cheaper alternate medications to patients. Similarly, other health system staff also felt after pharmacists, physicians and insurance companies were best positioned to provide this information. None of the professional groups surveyed felt that they were the strongest candidates to discuss lowering testing and general treatment costs with patients. Overall, respondents from all professional groups felt that insurance companies were best positioned to provide this information, followed by health systems. Similarly, respondents felt that health and hospital systems were best positioned to provide information about costs of tests and treatment, again, followed by insurance companies. Prescribers, such as physicians, nurse practitioners, physician's assistants, and RNs, felt that they were best positioned to have conversations about delaying and or foregoing care due to cost. Similarly, 46% of survey respondents felt that prescribers were best positioned to provide this information. A participant anecdote noted this participant was looking for ways in which to support patients' cost concerns. I would like training on how to have empathy when working with patients on cost issues and how to know what the most cost-effective alternatives are.
So one thing that we've heard a lot about, as Susan just mentioned, is that our survey respondents felt that pharmacists were best suited to answer questions about costs of medication. One suggestion that trended highly, and that you'll see listed here as opportunity number 3, was that for health systems that do not have an on-site pharmacy, to consider adding an on-call pharmacist to their care team. This would help patients at point of care be able to immediately ask questions related to medication costs. Similarly, as you'll see here in opportunity number 4, it was suggested to consider hiring and training staff to partner with patients at time of care to ensure that patients can get answers immediately about insurance and cost questions so that they could immediately determine if their proposed treatment plan was affordable. This could even be someone who can help patients figure out how to call their insurance company and stay on the phone to coach them with what questions to ask. And I know this may seem like a big list, but we wanted to make sure to include it because it was so strongly recommended by our survey respondents. But to make it seem slightly less daunting, we do have information, as I mentioned, in the resources section of our toolkit to help figure out how to do this.
Our findings suggest creating environments and workflows that make cost conversations a consistent and regular component of a visit and not relying on patient initiation. 82% of survey respondents felt that there's no easy way to bring up cost conversations, though they did report that the best time to do so was during patient intake and while discussing treatment decisions, and that doing this more frequently within these time frames would help increase the frequency of cost conversations. 52% of survey respondents indicated that patients initiate the majority of conversations about out-of-pocket costs, and that 39% are having these conversations at least weekly. Health system staff rarely initiate conversations about cost of care, as per our survey respondents, though when they do, they are about out-of-pocket cost to patients, cost of illness, and cost of coverage. One staff noted that they are looking for support to initiate and engage in cost conversations. Quote, could we create patient-appropriate tools or handouts to guide these cost conversations?
So one way to normalize these cost conversations, as you'll see here in opportunity number 5, is to really encourage them by proactively bringing up the issue of cost at check-in, on intake forms, while rooming patients, and while taking medical histories. Another suggestion we heard repeatedly is to hang posters in waiting rooms and other public areas to nudge patients to ask about costs and let them know that such questions are welcomed and encouraged. Another resource that you'll find in our toolkit is suggestions on how to add doing something like this into your workflow.
We were surprised to learn that staff recognize their race, ethnicity, perception of social status, and a role as a healthcare provider influences cost conversations. One physician noted, some patients are less likely to bring it up because I'm old and white.
So here we suggest that your health system make the time and find the resources to develop a health system in which cultural awareness is deliberate and which staff is aware and sensitive to the varying financial realities of all patients. This is opportunity number 6. And as you'll see in opportunity number 7, this is also a good opportunity to, at the very least, ensure that all visuals, such as posters, brochures, and videos, represent diverse patients. And I'd also like to add diverse staff if that is true of your health system team. You can also ensure that patient-facing materials specifically encourage patients to talk to their healthcare providers about cost by using wording such as, talk to your doctor if you're concerned about the cost of your medicine, medical tests, treatments, or procedures. Consider providing scripting for your providers and staff so that they're more comfortable with this type of conversation, both in terms of responding to it and initiating it.
So only 33% of respondents reported that their health system had provided training to staff on how to handle or redirect cost questions. 67% reported that their health system had never provided such training. Only 14% of our respondents reported that their employers provide specific training on how to discuss treatment options with their patients based on their ability to pay for it, meaning that 86% did not. 28% of respondents reported that they do not need trainings related to cost conversations and or that it was not applicable to their job. However, when asked about the types of topics that could be covered in trainings about cost of care, 72% of respondents offered a range of suggestions. One participant noted additional value to training that could include knowing where and how to redirect patients' cost questions to the appropriate personnel. training could be useful, but I don't believe as an RN it is within my scope of practice to provide this information. I should know, however, where to find the answer at least.
A tremendous gap exists between health system staff whose employer has provided training on discussing cost of care-related issues and those who feel they need to be trained on it. So there's a huge opportunity, as we point out here in opportunity number 8, for those who have not been trained on discussing costs with patients to do so. And one way to begin is with an organizational self-assessment. Our toolkit has links to some, and we hope that you'll find those useful. So we're now going to transition slightly and ask the question, what can we do to encourage these cost conversations? What are some actual actions that we can take? So the first thing we recommend is to learn what questions your patients are most frequently asking about cost and what resources your team can share with patients to help answer these questions. The second is to help your staff and colleagues engage in cost conversations so that they can appropriately respond to patients' questions around cost. And third, learn what your staff may want to be trained on so that they can have the most effective conversations as possible around cost issues. I was stunned by the honesty and the in-depth responses that we got in our survey. And perhaps some of what we learned will resonate within your own health system and with your team. Or perhaps you'll want to replicate our survey on an internal level to learn more about your team, what they'd like to learn, and what would help them feel more supported in these conversations. So this is the cover of our toolkit, Right Question, Wrong Person. And I'm going to show you a couple of screenshots in just a moment so that you can actually see some of the resources that I just alluded to. So this slide shows the resources that we provide for the action opportunity of learn what questions your patients are asking most frequently about cost, and what resources your team can share with patients to help answer these questions. So in the left-hand column, we have a list of the types of questions we learned that patients are asking, such as, what will it cost me? How much will I need to pay out of pocket, including copays and deductibles? What are my alternatives, cost and treatment-wise? Can you explain the costs to me? They don't make any sense. So then in the right-hand column, you'll see resources to share with patients with direct links. So these include, for example, helping patients understand the basics of costs of care, getting estimates for costs for medical treatment based on where the patient lives, reading about delaying or foregoing specific treatment, and filing a complaint for people who get a surprise medical bill, and even learning how to read their medical bill. We also know that there will be some potential barriers. For example, we heard from some survey respondents that patients do not ask questions about cost at all. So since we do want to encourage those types of conversations, we also offer a proposed solution, including conversation starters. Of course, we have similar types of resources for the other action opportunities in the toolkit that we talked about today, and I encourage you to look at those as well. I also want to show you an example of our resource list by subtopic that's included in the toolkit. As you'll see on this screenshot, this page has tools for patients and healthcare consumers separated out by cost estimators and money-saving techniques for general medical expenses, cost estimators and money-saving techniques for prescription medications, and resources for understanding and acting on medical insurance and medical bills. So examples include how to research healthcare prices, 9 ways to save on your healthcare costs, shop around for lower drug prices, how to read your medical bill, which is similar to the one that I showed on the previous slide. And our toolkit has almost 2 full pages of resources for healthcare systems and provider-led cost of care conversations, as well as general resources. So again, we hope you'll look at those, and we encourage you to use them within your health system. So we hope that this toolkit will be useful for you. And while I know we have plenty of time today to answer questions, Susan and I also invite you to reach out to us directly with any questions you have. We hope that you'll use and share the toolkit, which you can access with the link at the bottom of this slide. So at this point, I will turn it back over to Lisa, who I believe will be facilitating a Q&A session. And Lisa, you might be on mute.
Oops, so we're having dueling unmuting. Sorry about that. So thank you so much, both Beccah and Susan. We really appreciate both the work that you've been doing and your willingness to share that with us today. So we wanted to open it up for questions. And you can either chat or I believe you can unmute. I always lose track of. Yeah, I believe you can unmute as well. I see that Kelly, in response to somebody, just put the link to the toolkit in the chat section as well. I'm sorry, Kelly, you something to speak? Or somebody else? Okay, so I see one question. Does shared tools have cost discussions? If you could mute me. That's not me with the background noise. So Susan or Beccah, either one of you want to take that?
I'm sorry, I was unable to hear. Can you repeat the question? I couldn't hear it.
Sure. In the chat, do shared decision-making tools have cost discussions built into them?
Is that shared decision-making tools in general? I mean, I'm sure that there is an opportunity to build. I absolutely think that this is an opportunity to build cost discussions into shared decision-making tools, but I'm not. I can't speak to existing decision-making tools in general.
But Susan, maybe you could talk a little bit about the research that you did for the grant that was previous to that, about how many doctors have alternatives in mind but don't necessarily present them.
Absolutely. So one of the concerns about having these cost conversations is that nobody really knows the cost, or at least the people in the room having the discussion about treatment, or in that moment, right, when we were presenting our survey findings about ideal times to have cost conversations, and that was at intake or when making treatment decisions. And a huge concern is that no one really knows the cost. But in prior research, and it's actually recently been published in a special supplement in the Annals of Internal Medicine this past year, that we learned that doctors do tend to have an idea of which medications, treatments are costlier. And so while they may not know the exact amount, they can anticipate treatments and prescriptions that will cost that will cost period or cost more. And with that knowledge, they can often offer an alternative or a plan B should it turn out that the patient can't afford those medications. And this is often done in practices to avoid potential increased administrative workloads. So a lot of what I understand and learned in those interviews is that a lot of physicians experience a lot of burnout, specifically for these very reasons. A patient arrives at the pharmacy and realize they can't afford a prescription. They go back to their doctor. The doctor kind of has to almost re-look at that visit, and then they're kind of almost redoing the visit. And so some providers or physicians shared with me that they say, okay, it turns out you can't afford this medication. This medication's bounced back to me before with your type of insurance. My medical assistant has another prescription for an alternative. Then just call us back and she has instructions to give you that one. And that and in that way, providers can anticipate costs, have those cost conversations, and even plan for it to reduce those future burdens.
And I just want to say, from a technical standpoint, we did mute everyone because there was extra noise. But if you raise your hand, we'll be happy to unmute you. Or if you put in the chat like Sarah Wolseley did, we are also happy to unmute you. So did you unmute, Sarah? So Sarah, you should be unmuted.
Hey, hi you guys. Sarah Wolseley. I'm with CoMagine Health in Utah, and just thank you for this presentation. I'm excited to look at the toolkit. I just want to mention, I don't know if anyone has noticed the recent physician compare data that CMS has announced they've put out, but for larger organizations that have some patient-centered reports on the CMS website, one of the questions asked if the organization has, or the provider, but mostly organization, has talked to them about the cost of their prescriptions. So it's right out there in black and white, and we've noticed in Utah, a number of our large systems could benefit from support just like this to improve their ability to do these conversations, because it's the right thing to do, and it'll improve their transparency metrics that they might be interested in on the CMS Physician Compare. So just something to mention to folks. So this is very timely to that announcement.
Excellent. Thank you so much, Lisa. Kelly, that sounds like a post in the workplace to me.
Great.
I hadn't seen that. Did any others want to react to that? That's a terrific observation. Maybe even thinking about building it into future, versions of the toolkit or other. All right, others.
It does look like there's another question in the chat box, Lisa.
Oh, there we go. Sorry. So from Polly Malloy, if practitioners or pharmacists don't to keep up with insurance coverage for patients, any suggestions? Oh, and then Sarah just chatted in the Physician Compare link. Thank you so much. So Beccah or Susan, any thoughts on that challenge of how to keep up with different kinds of insurance plans or maybe changes to benefit design?
Based on my just interviews and research about cost conversations, this is a huge, this is a sore point, is changing plans and programs, and really it is hard to keep up. And kind of what I was talking about before, it's really providers are learning based on trial and error, and they're learning from those errors and trying to adjust with other patients. I do know, I learned only from interviews, is that there are some health systems, and I believe it's Epic, where that providers describe some like different colored little, I think describe them as lights or something that shows something is covered or not. So to answer to that question is, I understand is there opportunities to develop software that could that could keep up with those, but that's as much as I know for that.
And just to add to what Susan said is part of the reason we did the survey was because there's not amazing tools out there to just get the cost, and we wanted real solutions that could be practical. So that is why there are things like trying to find how you can use your staff to help patients find out how to get their insurance information. They're not necessarily perfect solutions, but we have tried to crowdsource from people who are really working on these issues and have implemented asking questions about cost in their workflows to give us solutions to what might be able to work in today's real world, with the hope that there will be better technology and better information as we continue to work on this topic.
Hi there, this is Steve Smith. Hope you can hear me.
Mm-hmm.
Great. Well, I wanted to thank Susan and Beccah. Wonderful presentation. I wanted to share a little experience and to give a little bit of pushback about the statement that physicians, pharmacists, et cetera, are in the best position to initiate discussions with patients about costs. I'm a family physician, and I certainly think I'm in a good position Well, let me share you an experience. With the help of a mini grant from the Robert Wood Johnson Foundation, we developed a teaching tool on diabetes, the cost of care of diabetes for our patients, to be used by community health workers. And we trained the community health workers to use this tool to engage with low-income, highly vulnerable populations. I had one patient whose diabetes just was not coming under good control. Spanish-speaking woman. I always used an interpreter. Couldn't figure out what was going on. I referred her to one of our community health workers, and lo and behold, her insulin was costing her too much, and she basically wasn't using it, but she was either embarrassed or ashamed or whatever to tell me about it. So once I found this out from the community health worker, I worked with her. We used a 340B program, got the patient the insulin for less than $13 a month, and everything worked out nicely for that patient. So I just want to say your study really takes it from the provider's perspective, and I think your conclusions are appropriate. But if you ask it from the consumer's perspective, they may have a different opinion about who might be best to initiate those discussions with patients, and I certainly would highly recommend the use of community health workers in that regard.
Thank you so much for that anecdote, Dr. Smith. I absolutely agree with you in regards to the role of community health workers. They're established, trusted resource, and do understand the community in ways as we as health systems and healthcare providers do not. I did conduct with that same study, we did conduct patient interviews. And it's interesting what patients state they're willing to do, and then when you transition to asking individuals what they actually have done. So especially among vulnerable populations, and even pushback culturally, and some cultures where healthcare providers are put on this very hierarchical, higher level position. They have really high respect for providers in that they often will not speak up and ask questions. We got a lot of pushback in terms of time. I only have 15 minutes with my provider. I don't want to use that time to talk about cost. One quote is, my doctor got an MD, not an MBA. He's not the right, or he or she's not the right person to talk about cost with, or I just don't want to, or I just don't ask questions because I just want to get all the information I can from them and just let them talk at me so that I get the most of my 15 minutes. And then outside of that, there's the cultural and the kind of hierarchical deference to providers. But with that, we do have, given the right tools, resources, and almost permission to engage in that conversation. Patients or these participants were much more willing to engage in these conversations. And I believe this toolkit does provide patient-oriented educational materials to really encourage that, and that's why another recommendation of our toolkit was to put those posters or a notes or something around your office to really encourage patients to initiate those conversations. But as I see it now, from our previous research, there is some reluctance, but that doesn't mean that all patients aren't going to have that. There are a number of participants in that previous study who said, absolutely, I've had this conversation before and it got me this.
And just to follow up on Susan, one of the things we really thought about, and I think we're hoping to look more deeply into the data, was the idea that probably the physician may not be the person being asked. So it's kind of why we came up with the right question, wrong person. But we really wanted to push health systems to think about, if the person who doesn't have any answer is being asked, how can we train them to get redirected into a system where they either can find that answer or can get that person to the right person? So if there is a health worker, we really are not being prescriptive necessarily on who the right person is, but trying to help health systems think about how their workflow works and how to have receptive people at all levels, so that if somebody calls in to the billing person and says, well, I'm just not going to take this, then the billing person who has no clinical background doesn't just hang up. They say, that's okay, that's an option. Let's have you get back to your doctor. Hopefully we'll have more coming off of this survey too.
Great. Others? Let's see if there's any more here.
Hey, this is Sarah Wiltsey, and just again, and just encouraging folks to share this with different fields. I have a dermatologist colleague that has talked about high deductible plans, has made it very important for her to discuss cost with patients. If she takes off one skin lesion or two or three, the cost can rack up for patients, and those high deductible plans, they don't understand they'll be paying for, that cost. And it's become really critical to her patient satisfaction scores that she has those discussions so people aren't really surprised. And she has to sort of guide, hey, I think this is melanoma, we need to work on this, but she'll leave them in the room to call their insurance or whatever to make sure they're aware of the bill they're going to get, because PATH can be very high. So I think we're actually going to build some things, and I can't wait to share your toolkit with her, into her talk to update primary care on dermatological care, that talking about cost with dermatology procedures is an essential portion of the care for patients so that they feel safe and respected and can make those decisions with guidance on the cost. So just another editorial there.
Great. It certainly has been a changing landscape in these last several years, hasn't it, in terms of high deductibles and the increasing expectation and pressures on both patients and clinicians to understand those costs. So I don't see that changing anytime soon, fortunately. Others? Okay, I'm not seeing more chatted questions. Anybody else want to unmute and ask a question? All right. Well, I might just ask Beccah and or Susan, any other, anything else you want to add about plans for future work or ongoing studies? You've mentioned a little bit of that in your presentation, but anything else you want to add along those lines?
I know. I think it would be interesting to really explore how these cost conversations are kind of. Well, I think where our research kind of stops short at this moment is just normalized cost conversations, but we really haven't yet dissected really the language around cost conversations. So, for example, a lot of participants in my previous study, patients, don't necessarily want to hear the word cost. Also, that cost doesn't necessarily just mean out-of-pocket costs, that your healthcare provider can help you with those other type of costs, like the life costs, such as transportation. And I did hear that in the research that we did in some rural communities, that a broken arm, well covered by the insurance program in their community, was incredibly expensive for the family that was working on hourly wages, and the nearest town was 2 hours away, and it meant having to eat out. And that to patients, that we also need to signal to them that, there are things that we providers might be able to do to mitigate even those types of costs. So, and all that in the context of patients really hearing, like, I don't want to talk cost. I don't want someone to put a dollar sign to my health and healthcare. So I would personally be really interested in seeing what the best practices, maybe, I don't know if that's the right way of framing it, might be around having those conversations.
We'd also love to hear. Oh, you go ahead first, Beccah.
I was just going to say, I would add, it's a good question that you asked, Lisa. I would be interested if there were health systems that were interested to take the toolkit and really do a pilot with it and implement it and figure out which of these resources or topics really spoke best to their health system, perhaps by even doing an internal survey similar to ours and replicating it, and then finding out by using the resources in the toolkit or the suggestions what happened and if there were changes. So I'd be, that's obviously a much bigger and longer term type of a thing, but I would be interested, of course, in that.
That was the same thing I was going to say, but I would say that even if you have feedback on using the toolkit, we'd love to hear it. And as always, we're at the Choosing Wisely Learning Network happy to talk with you about implementation. So if you are interested in implementing this toolkit and want to think about ways to test it or even just ways to implement it that are specific to your practice, we are happy to have one-on-one conversations with you. And Lisa, it looks like there's another question in the chat box.
Okay, trying to scroll down here, sorry. So Daniel, shall we unmute? You want to jump in, Daniel? He's asking to talk about solo and small practices that have low levels of resources. How do we address some of these issues in those practices?
I could weigh in. So a lot of the interviews that I did with physicians happened to be from those smaller practices, and the sentiment I felt is that there's this dying breed of providers because working in a small solo practice is really challenging these days. But I actually found that in those smaller practices, they actually have a more intimate relationship with their patients. So like one provider talked about running into his patients at Walmart and just seeing them. So it's interesting because the dynamic there, and I'm totally generalizing, but at least from my interviews, that they do have a stronger understanding of that patient population. And I also recall, and I haven't completely, that they also were a little more fine-tuned in terms of the types of patients and patient insurances they saw. So, for example, some practices had an older patient population, so they knew how to navigate those insurance types, or they were in a specific community that perhaps served a specific company, and then they happen to know those insurances quite well too. It's that kind of forces that I think in discussing that too, and the whole idea of normalizing cost conversations. I would also advocate is normalizing cost conversations because the reverse happens with what we saw with patient reluctance to engage in cost conversations with certain staff based on race, ethnicity, and social status. The flip happens with providers not engaging with patients, having cost conversations because of assumptions of social status. And it's interesting as our health insurance programs shift that individuals who are in more private companies and higher income individuals often have higher deductible plans and actually might be bearing more out-of-pocket costs. And that's more reason to really have normalize those cost conversations.
And I'll add, there's an article that it's under embargo right now, so I can't say a lot of detail about it. I just looked at it though as a review. And to back up or to further complement what Susan was just saying, this article was talking about in smaller towns and smaller practices, and the ability to have these conversations more easily for exactly the reason that Susan was saying, that they run into them, at different places, at stores and restaurants in towns, but also there's less of a pressure to move so quickly through patients, and so there's more time to slow down and have those conversations. So I don't have the date of when that paper will be coming out, but it echoes what Susan was just saying as well.
Beccah, if you send that paper to me, once it's published, we're happy to post it on Workplace.
Sure, happy to.
Great. Other thoughts or questions? Okay. Great. Well, I think we might be at a wrap here then. Last chance. Anybody want to chat or jump in? Otherwise, Kelly, I will turn it back to you with a big thanks again to Beccah and Susan.
Yes, I want to again thank Beccah and Susan for the great work they did with us and for presenting to everyone, and just reiterate my offer that if you would like any assistance or if you can provide any feedback on this toolkit, we'd like to keep this conversation going. So thank you everybody for showing up today, and we will talk to you next month.
And we definitely hope the earthquake is done.
Yeah,
it's done. It was very quick, but shocking.
4.3? Oh my God.
Thank you, everyone.
Thank you.
Okay, thank you.